All right, so these are going to be the drugs that you're going to use in psychiatry, and this is something that you really, really, really need to know, not only for step 2 and 3, but for the wards. These are very commonly used drugs, and so this is a good place to start before reviewing psychiatry, and it's a great place to end. So you're going to want to consult these slides over and over and over again, because this is very, very high yield for boards. So we're going to talk about the antipsychotics, antidepressants, stimulants used for mood disorders, and anxiolytics, which are the benzodiazepines, barbiturates, and the benzodiazepine-like drugs. Okay, so antipsychotics. So the mechanism for antipsychotics is dopamine antagonism, and as you probably remember if you watched the psychotic disease lectures, the primary means for psychotic disorders is excess dopamine. So antagonizing dopamine is therefore a useful way to block psychotic symptoms. So we divide antipsychotics up into two classes, typical and atypical. Typical are the older ones. So we have our high potency ones, and as you can imagine, these are the things that are going to be more sedating. They're going to have a quicker effectiveness, and that's haloperidol. And then the low potency, which is chlorpromazine. Risperidone is an atypical antipsychotic that doesn't really fit into either typical or atypical class because it doesn't actually do the same thing as either. So typical antipsychotics only block D2. Atypical antipsychotics block D2, D4, and serotonin 2. With risperidone, you're only blocking D2 and serotonin 2, not D4. So risperidone is an atypical antipsychotic, but it needs to be kind of in its own class. So that's why I excluded it from the atypical antipsychotics. And then your atypical antipsychotics are your antipsychotics primarily used for maintenance therapy for patients who have psychotic disorders. And those are aripiprazole, clozapine, olanzapine, quetiapine, and ziprasidone. And I broke it up here into a visual form if you're more of a visual learner. So here's the trade names that you'll hear thrown around on the wards. If you've been on the wards for a long time, you've probably forgotten some of the generic names. Definitely important to remember the generic names, though, for the USMLE, because that's how they frame the questions. They use generic names. Okay, so when do we prescribe antipsychotics? Well, obviously, we're going to prescribe them in psychotic disorders. So schizophrenia, schizoaffective disorder, brief psychotic episodes, schizophreniform disorder, delusional disorder, and so forth. We'd prefer to use atypical antipsychotics because on these patients we're going to be using these antipsychotics for a long time. Schizophrenia patients are going to be probably using them for the rest of their lives. So we like to use atypical antipsychotics because they have fewer side effects, which we'll talk about in a bit. Acute agitation is a good time to use antipsychotics, and that can come up at any time on any ward. So if a patient is agitated, we like to use high-potency antipsychotics. So Haldol is the best one to go to. You can also use Geodon, which is ziprasidone, and that can be useful in patients for acute agitation. Major depressive disorder or bipolar II disorder, you can use antipsychotics as an adjunctive therapy to the SSRIs that they're going to be on in the first place. And we particularly use aripiprazole or Abilify for these patients. Movement disorders that involve basal ganglia dopaminergic system disorder, that's Huntington's disease and Tourette's syndrome. Remember, Huntington's disease directly implicates the basal ganglia, and Tourette's syndrome is thought to be a condition of excess dopaminergic stimulation. So we do use antipsychotics in these patients. For Huntington's disease, it's primarily palliative, and for Tourette's syndrome, it's therapeutic. So typical versus atypical. Typical is okay for acute care. So agitation, it's fine to use Haldol. There's no problem in that. But we prefer to use atypicals for long-term management. Now, both typical and atypical are going to have side effects, but the side effects for atypicals are not as severe as the side effects for typicals. And we're going to talk about those in the next slide. So atypicals are good for long-term management, so aripiprazole, especially for patients with depressive symptoms. Clozapine, we do not use clozapine as a first line, and the reason is because it causes a precipitous decrease in white blood cell count, which can be fatal. So we avoid clozapine at all costs. Olanzapine, quetiapine, and ziprasidone. Ziprasidone, we also like to avoid that one because it can prolong the QT interval. So in patients with a long QT interval, we try to avoid that. But if the patient has a normal QT interval, certainly ziprasidone can be used. Risperidone is good for elderly patients. So remember, risperidone only blocked D2 and serotonin 2. It doesn't block D4. So the result of that is it causes less sedation than the other atypical antipsychotics. And that's why we like to use it in elderly patients, because if you sedate older patients, what's going to happen? They're going to be more likely to fall down. And we don't like that in elderly patients because a lot of them have bone problems to begin with. So good way to remember this is rise and shine, or wake up, rise and shine with risperidone. And we like to use this in elderly patients. And the big problem with atypical antipsychotics, and it's a side effect, but it's not a deadly side effect, and that's weight gain. So that's not a big deal. And let's compare this to the typical antipsychotics. So actually, let's first talk about effects of antipsychotics in general. So dopamine works on three different systems. There's a mesolimbic and mesocortical system, and excess dopamine there is going to cause psychotic symptoms. So your block dopamine in the mesolimbic, mesocortical system, you're going to decrease psychotic symptoms. That's good. That's why we use antipsychotics. The nigrostriatal system, if you block dopamine there, you're going to cause extrapyramidal symptoms. Nigrostriatal is our movement of the basal ganglia. Nigro, substantia nigra. That's what degenerates in Parkinson's disease, and it causes movement symptoms. So blocking dopamine there is going to cause Parkinsonian-like symptoms, and that's tardive dyskinesia, neuroleptic malignant syndrome, and akathisia. Tubuloinfundibular system is the system in which prolactin works on. Dopamine, remember, is also known as prolactin inhibitory factor. So by blocking dopamine, you're actually going to increase prolactin. You're going to take your foot off the brake. By getting rid of prolactin inhibiting factor, or dopamine, you're going to increase prolactin by disinhibiting prolactin. And remember what prolactin is for. After delivering, new mothers secrete prolactin. Why? To secrete milk. So galactorrhea is going to be a side effect of the increased prolactin you get from antipsychotics. Along with galactorrhea, what's going to happen? Your breasts are going to get big. They're going to get tender, gynecomastia, or breast tenderness. And then amenorrhea for women, because prolactin directly blocks the menstrual cycle. There are antihistaminic properties of all antipsychotics, so that's going to cause sedation, and that can be good, especially when we want to sedate a patient who's agitated. There's going to be alpha-1 adrenergic blockade properties of antipsychotics, which can cause hypotension, so you need to keep an eye on that. And then there's anticholinergic properties of antipsychotics, and that's going to cause constipation, dry mouth, dry eyes, bradycardia, etc. Okay, so let's talk about the movement symptoms that you get from primarily the typical antipsychotics. And this is why we use the atypical antipsychotics for long-term therapy. So why do we not like to use typical antipsychotics on a long-term basis? Because the main adverse effect, the most serious adverse effect, is extrapyramidal symptoms. So we prevent this by sticking to atypical antipsychotics for long-term use. If we need to use typical antipsychotics like Haldol, then what we need to keep an eye out for are the extrapyramidal symptoms. And the first of which you would see, and it comes on within hours to days of treatment, is acute dystonia. Acute dystonia is nothing more than spasms of various muscle groups in the body. So you may see torticollis, which is a spasm of the neck muscles. You may see oculogyrate crisis, which is where the eyes, you lose control of the eyes and they spin. And also any kind of widespread muscular spasm. And this can be really, really problematic to the patient, and they're not going to want to stay on therapy because they're getting these muscular spasms, which can be painful and irritating. And so the treatment for this is going to be anticholinergics, so diphenhydramine or benztropine. And that will generally cause the acute dystonia to abate. If it doesn't, then you're probably going to want to move over to an atypical antipsychotic. Akathisia comes on months after treatment, and what that is restlessness and tremor. And the way to treat this is primarily just to monitor the dosage closely, lower the dose if possible, and as always, change to atypicals if possible. And usually we don't see these because we go to atypicals right away. There's very few cases where we need to have patients on long-term typical antipsychotic therapy. And then the most severe extrapyramidal symptom is tardive dyskinesia. And this is irreversible. And the symptoms of this is chorea, especially involuntary movements of the facial muscles and the jaw. And the only treatment for this is to switch to atypicals because this is irreversible. So even when you stop the typical antipsychotics, the patients will continue to have their movement symptoms. Okay, this is something very, 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 very important to know about typical antipsychotics and what they can do, and very rarely atypical antipsychotics. So neuroleptic malignant syndrome is an acute problem from antipsychotics, and it is a medical emergency. Unfortunately, it's very underdiagnosed because the symptoms appear very similar to lots of other things. So the symptoms of neuroleptic malignant syndrome, and this is directly caused from the antipsychotic, are hyperthermia, muscular rigidity, cramps, tremor, severe hypertension or hypotension, tachycardia, delirium, agitation, and seizure activity. And the mechanism by which we get neuroleptic malignant syndrome is very complicated, but you can think of it as a calcium effect on muscles, released from the sarcoplasmic reticulum. So the diagnosis for neuroleptic malignant syndrome is to keep a high index of suspicion on any patient on antipsychotics, and definitely keep an eye out for hyperthermia and muscular rigidity because they are the most specific for neuroleptic malignant syndrome. Your labs, if you get them on CMP, you'll have an increased CPK and an elevated white count. And along with your high index of suspicion for neuroleptic malignant syndrome and your labs, this should be diagnostic of neuroleptic malignant syndrome. The treatment for NMS is going to be immediately discontinuation of the antipsychotic, as well as starting IV dantrolene, which is a muscle relaxant. That's going to get rid of the muscular rigidity and stop continued increases in temperature. You're also going to want to have supportive management, watch your vitals, ensure adequate hydration with a large bore IV needle in case you need to pump IV fluids if you have a precipitous drop in blood pressure. You're going to want cooling pads to reduce the temperature and have benzodiazepines ready in case seizure activity develops. This is a medical emergency, so make sure and keep a high index of suspicion. Okay, so the antidepressants, there are various mechanisms for the antidepressants, but in general, they all cause an increased availability of serotonin. By far, the most commonly used antidepressants are the selective serotonin reuptake inhibitors. We have citalopram, escitalopram, fluoxetine, which was the original SSRI, Prozac, fluvoxamine, which is primarily used in OCD, paroxetine, and sertraline. We have tricyclic antidepressants, which because of their side effects have fallen out of favor, but they are used in various circumstances, and that's amitriptyline, clomipramine, and imipramine. We also have monoamine oxidase inhibitors, which are rarely, if ever, used in depression, and always they'd be second line, which is phenelzine and selegiline. And if you recognize selegiline from your neurology, it is because it is used to increase your dopamine availability in Parkinson's disease. And then we have others: bupropion, desvenlafaxine, mirtazapine, trazodone, and venlafaxine. And these all have very important uses, particularly when patients do not do well on SSRIs. So what are SSRIs? Well, they are by far the safest and the treatment of choice for major depressive disorder, in which they're most commonly used, and any other mood disorder with significant depressive symptoms, particularly bipolar II disorder and dysthymia. Treatment of choice for long-term therapy, so it is used in other, not just the mood disorders, it is used in anxiety disorders as long-term therapy. Remember, in anxiety disorders we use benzodiazepines for acute care, but for long-term therapy we use SSRIs. And so panic disorder, generalized anxiety disorder, social anxiety disorder, and obsessive compulsive disorder. And it's also useful in therapy for bulimia nervosa, which, remember, is the patients with eating disorders that are of normal weight. So the adverse effects of the SSRI is going to be sedation, because we increase our availability of serotonin. You're going to have a reduction in appetite and hence weight loss, and that can be a good or a bad thing, depending. You're going to have sexual dysfunction, which is actually the number one side effect that patients will report, particularly men, because it causes a delay in ejaculation. Occasionally, SSRIs will cause diarrhea. But in general, very important to remember that SSRIs are very well tolerated. They are, by all means, our first line of therapy for any kind of depressive symptoms and anxiety disorders, and they are very well tolerated. Tricyclic antidepressants were our original therapy for depression long ago, but since then they've fallen out of favor since the advent of the SSRIs. Why? Because patients that are depressed are, of course, more likely to commit suicide. And tricyclic antidepressants have a very high mortality in overdose. So anytime you prescribe tricyclic antidepressants to patients, and there may be times when that come, if they fail SSRIs, if you have tried many drugs and they haven't responded, then tricyclic antidepressants may be used, but you're going to want to assess the patient for suicidality, and you're not going to want to give them much more than a two-week supply of their tricyclic antidepressants, because these are very deadly in overdose. So they are second-line therapy for OCD. Remember, the first line for OCD is going to be the SSRI fluvoxamine, or Luvox, and then the second line would be the tricyclic antidepressant clomipramine. Enuresis, particularly in children, nocturnal enuresis, the first line is going to be desmopressin, or DDAVP. The second line will be the tricyclic antidepressant imipramine. And then there's various pain disorders that tricyclic antidepressants are prescribed for. But the first line is going to be the drugs that work directly on nerves, which are newer, and that's gabapentin or pregabalin. The second line will be the tricyclic antidepressant amitriptyline. So what are the adverse effects of the tricyclic antidepressants? Well, orthostatic hypotension, and that's primarily because of the anticholinergic symptoms, which include bradycardia. And of course, constipation, dry mouth, and dry eyes. And of course, there's an adverse effect that patients can use these in overdose in a suicide attempt. The monoamine oxidase inhibitors are rarely used for depression due to the significant adverse effect of hypertensive crisis. And that generally happens either if you take too much of the monoamine oxidase inhibitor, or if it's used accidentally in combination with tyrosine-rich foods, the most prominent, which include nuts and aged cheeses, and certain medications, especially the stimulants and medications used for asthma. The most common MAOI to be prescribed is selegiline, and remember we said that that's used for Parkinson's disease because it increases the availability of dopamine. For the USMLE, you're not going to be using MAOIs for depression. So some of the other meds that are used as antidepressants, the most prominent includes bupropion, And why bupropion? Because bupropion has minimal sexual side effects. So you're going to get the guys that come in and they're going to say, Doc, I can't use this medication, I can't stay on my Zoloft because I can't have orgasm when I'm having sex. And while that may sound like a very minimal side effect, for people, especially people with mood disorders or with anxiety disorders, sex is important to them, like it is to all of us. And so you're going to want to treat their depression, but you're going to want to make sure that you maximize their quality of life, as you would for any patient. So bupropion is a great medication for patients complaining of sexual side effects. It is also, it blocks the reuptake, in addition to serotonin, it also blocks the reuptake of norepinephrine. So this is good for patients with hypersomnia. Remember that in depression, one of our CAPS symptoms is a disturbance in sleep, and that can be either insomnia or hypersomnia. If the patient has hypersomnia as a symptom, then bupropion may be a good drug to go to as a first line because this is an activating antidepressant. So it's good for patients with hypersomnia. One of the downsides to bupropion is that it increases the risk of seizures. So bupropion you may otherwise know as Wellbutrin, and it increases the risk of seizures. So not a good medication to go to in any patient who's had recent seizures or has a history of epilepsy. Venlafaxine, otherwise known as Effexor, is also an activating antidepressant, and you can use this just like bupropion. The only difference it has from bupropion is that it does not increase the risk of seizures. Trazodone, on the other hand, is highly sedating. So this is good for patients that are depressed, that you want to use an antidepressant in, but that are complaining of insomnia. You can also use this medication in patients who simply have insomnia, but it is not going to be our drug of choice on the USMLE for patients with insomnia, unless trazodone was the only medication you found on there and you didn't find the drugs we're going to talk about for insomnia, which will be coming up. So good for major depressive patients with insomnia. Mirtazapine increases appetite and weight, and it has faster onset of action, and this is unlike all the other drugs we've been talking about for depression. So the great thing about mirtazapine is if you have a patient who's older, if you have a patient who's thin, then you don't want them to have a decreased appetite. So using mirtazapine will be preferable because this will allow the patient to bulk up. And remember, one of the CAPS symptoms is loss of appetite. Or an increase in appetite. So if the patient has a loss of appetite, mirtazapine is a good drug to go to. So it's good for underweight and elderly patients, and because it has a faster onset of action, it's good for more severely depressed patients. All the drugs we've talked about are great drugs of choice as far as the SSRIs. So you're generally not going to have much conflict, but know the specific qualities of each drug and what their upsides and downsides are, especially these four. Okay, so if you've been on the wards and you've been in psychiatric units or psychiatric clinics, you've probably seen practitioners, psychiatrists use stimulants for mood disorders, particularly modafinil, which is known as Provigil. And it's used clinically a lot, and it's generally effective. But it is not approved by the FDA for this purpose. So on the USMLE, stimulants should never be used to treat mood disorders, even as adjunctive therapy. If a patient has a mood disorder and they have hypersomnia, and that's a problem, and you need to switch medications or start a medication on a depressed patient with hypersomnia, then you're going to want to use an activating antidepressant, which we just talked about is bupropion and venlafaxine. For the USMLE, the only place stimulants are going to be used are narcolepsy, ADHD, and excessive daytime sleepiness due to sleep apnea. Okay, so moving on to the mood stabilizers, we have lithium, which is always going to be your first drug of choice for any of the bipolar disorders and schizoaffective disorder. With schizoaffective disorder, we also have to obviously prescribe an antipsychotic, and remember always, the psychotic symptoms are more problematic than the mood symptoms. So if in schizoaffective disorder, yes, lithium is good, but we have to make sure we have an antipsychotic with that. Divalproex is also known as valproic acid or valproate. That's good for the rapid cycling bipolar disorder. Carbamazepine or Tegretol is always second line. There are some significant side effects that we have with that have made it fall out of favorability. And then the anti-epileptic drugs, Topamax and Lamictal, most commonly used for mood stabilization. And these are good in pregnant patients just because we want to move them off of lithium and divalproex because there are some teratogenicity with these. So lithium is our go-to drug in the bipolar disorders and in schizoaffective disorder. The adverse effects with lithium include weight gain, which can adversely affect patient compliance, GI upset, tremor, hypothyroidism, and polyuria. Lithium is highly teratogenic, and we definitely never want to use this in pregnancy. It can cause Epstein's abnormality, which is a congenital heart defect. We want to monitor levels of our patients with lithium and ensure that they're below 1.5 milliequivalents per liter. Patients that are high on lithium, that have higher than 1.5 milliequivalents that are in lithium toxicity, they'll usually present with tremor. The best way we can keep their lithium levels low but therapeutic is to make sure that they're ensuring adequate hydration. Very high lithium levels may require hemodialysis. Divalproex is our treatment of choice in the rapid cycling bipolar disorders, or if lithium is ineffective. The adverse effects here are similar to what we find in lithium with sedation, but in addition we're going to have hepatotoxicity and cognitive dulling. Divalproex is also teratogenic, and we see the neural tube defects, namely spina bifida. Carbamazepine is a second-line treatment in the mood disorders, and the reason is because it causes a severe agranulocytosis in some patients and hepatic toxicity. We're never going to use this in patients with pre-existing liver disease. The adverse effects, of course, are significant sedation, hepatotoxicity, and agranulocytosis. If you need to prescribe this, if your lithium, your divalproex, and any other mood stabilizers, namely the anti-epileptic drugs, have been unsuccessful, then you can use carbamazepine, but you're going to want to draw LFTs on these patients to ensure that they're normal. Okay, so let's talk about the sedative and hypnotics. We have benzodiazepines, barbiturates, and the benzodiazepine-like hypnotics, which I just alluded to earlier. They are the drugs of choice for insomnia. So benzodiazepines are primarily used for panic disorder, anxiety disorders, insomnia, and status epilepticus, which is seizures, convulsions lasting longer than 15 minutes. And those are midazolam, diazepam, lorazepam, temazepam, triazolam, alprazolam, clonazepam, and chlordiazepoxide. And I'm just going to point out right now that one of them I'm missing is oxazepam, O-X-A-Z-E-P-A-M. Oxazepam, temazepam, right here, and lorazepam, right here, are the best benzodiazepines. When you're going to use a benzodiazepine, they're the best ones to use in patients with liver dysfunction. And the way to remember that is OTL, outside the liver. They're the best ones to use in patients with liver dysfunction because they're metabolized outside the liver. Okay? So remember that. Oxazepam, temazepam, lorazepam for patients with liver failure. So all these benzodiazepines, though, are good for panic disorder, anxiety disorder, insomnia, not so much status epilepticus. We'll talk about that in a little bit. But these are all good. They, like the SSRIs, though, they are, generally we use each one in different cases. So we'll talk about the specifics in a little bit. Barbiturates are rarely used nowadays. They were originally used for insomnia and for panic disorder, but now that we have the benzodiazepines, because barbiturates have such a high toxicity profile and can be used in suicide attempts, they are rarely used anymore. The only time they are used first line is for infantile seizures, and they can be used second line for status epilepticus after we've given a benzodiazepine a couple times. Okay, so the benzodiazepine-like hypnotics are widely used for insomnia. They have a slightly lower abuse profile than benzodiazepines, and they can be used for a longer time. And that's zolpidem, which is Ambien, Zaloplan, which is Sonata, and azopiclone, which is Lunesta. And if you watch TV, it's very difficult to go 5 minutes of commercials without seeing these kinds of drugs, especially if you watch TV at night like I do, because lots of people that watch TV at night are probably in need of sedative hypnotics. So, benzodiazepines. So I divided these up a little bit. And benzodiazepines, in general, they all share the mechanism that they increase the frequency of the GABA-A chloride channel opening. Remember, chloride is a negative ion, so it's inhibitory because it decreases the charge inside the neuron. So the way I divided this up, it's somewhat based on their onset of action and their duration of action. It's not exact, but this is sort of clinical experience speaking here. So these three here, midazolam, which is Versed, diazepam, which is Valium, and lorazepam, which is Ativan, these are primarily used in panic attack and status epilepticus. These ones work fast. They come on fast and they go fast. So these aren't going to stick with you very long, but they're going to come on nice and fast. So that's very useful in panic attack. Panic attacks don't last very long. But when we want a drug for a panic attack, we're going to want something that works quick and that wears off quick. Same thing for status epilepticus. When somebody's having a seizure, we're not going to want a medication that takes 5 hours to work. We're going to want something that we can pump into somebody's vein and it's going to work fast. And so Versed and Ativan, midazolam, and Valium, midazolam, diazepam, and lorazepam are best for status epilepticus. So we use these three primarily for panic attack and for status epilepticus. Temazepam, triazolam, and alprazolam are primarily used in insomnia, anxiety disorders, and panic attack. So particularly temazepam and triazolam have been used in insomnia, but they have fallen out of favor because of the drugs we're going to talk about on the next slide. But these three, I wouldn't use these ever in status epilepticus, but they can be good for severe insomnia and for anxiety disorders, and they can be used for panic attack too. Clonazepam and chlordiazepoxide, these are the drugs that don't come on very fast, but they last a long time, and they last at a low level. And that's a good thing if you're treating long-term panic disorder. So somebody that has panic disorder and they have panic attacks frequently, and you want to reduce the frequency of the panic attacks, you're going to want to have a low basal level of benzodiazepine in their blood system all the time. So you're going to want a drug that doesn't necessarily come on super fast and super intense, but that has a nice low level that's going to last a long time. So the best ones for that is clonazepam and chlordiazepoxide. Chlordiazepoxide is very commonly used for alcohol withdrawal. So when you have a patient that is an alcoholic that is going to be in the hospital for some period of time, really any period of time, because they're not going to be drinking alcohol, at least they shouldn't be drinking alcohol in the hospital, you're going to want to make sure that they have a benzodiazepine. Why? Because when you go through alcohol withdrawal, you have a risk of developing delirium tremens, which does have a significant mortality rate. So chlordiazepoxide, given scheduled, is good for patients that are alcoholics who come into the hospital to treat alcohol withdrawal and as prophylaxis for delirium tremens. So remember that not all benzodiazepines, just like not all SSRIs, and not all antidepressants, and not all antipsychotics, not all benzodiazepines are born the same. Okay, so no kind of this spectrum here. The adverse effects of benzodiazepines, of course, sedation, that can be seen as a good thing because sedation sometimes is what we want from our sedatives, but that can be an adverse effect if a patient takes it at the wrong time or if they're abusing it. Benzodiazepines, although not so much like the barbiturates, benzodiazepines still do have an abuse and addiction and withdrawal profile. So you'll want to keep an eye on that. They are scheduled, so these patients are going to have to get their prescription in a hard copy form. And then, of course, there is the adverse effect of overdose. Patients will a lot of times use benzodiazepines as a suicide attempt. The good thing is that benzodiazepines, you'd have to take an awful lot to be successful in suicide, and most of the time the only way you're really successful is if you take it in consort with other sedative drugs, particularly alcohol. Good trivia to know that the antidote for benzodiazepines is flumazenil. Not used clinically, really, even in the ER, but if you're given a question that says the patient overdosed on benzodiazepines, which of the following is the treatment of choice, and you're given a bunch of drugs and flumazenil is one of them, that's your answer. Okay, so these are the benzodiazepine-like hypnotics. These are not benzodiazepines, but they act like them. And they include zolpidem, zalopon, and azopiclone. So you see commercials for these all the time, Ambien, Sonata, and Lunesta, respectively. Any of these are the right answer as pharmacotherapy for insomnia. Now remember, what is the first treatment of choice for insomnia? And it is going to be behavioral adjustment, sleep changes. You're going to want the patient to have good sleep hygiene. So behavioral changes is the best treatment of choice for insomnia. So making sure that the patient is going to bed in a dark room, that they have, that they're not reading and doing their homework and sitting on their computer while they're in bed, that they are going to sleep in a comfortable room, that they're not taking naps during the day. That's the number one treatment for insomnia. If we use a medication, we're going to use a benzodiazepine-like hypnotic. And any of these are a fine choice, but azopiclone is the best one if the patient has problems staying asleep. So Ambien and Sonata and Lunesta will all help you get to sleep, but studies have shown that azopiclone, Lunesta, is going to be the best for maintaining sleep. All of these drugs are, like I said, drugs of choice for insomnia if they're given as answers. And they are preferred over the benzodiazepines and antihistamines, even though in the clinical setting, benzodiazepines like triazolam, antihistamines like Tylenol PM, and even trazodone, which is an antidepressant, they may all be given as therapy in the clinic for the USMLE. These are the drugs you're going to use for insomnia, okay? And this was a hockey game I went to recently, Minnesota Wild, and I got to sit like 3 levels up from the ice. It was pretty sweet. So, anyway, hope to see you in the next section.